Welcome to the launch of our report, Under Pressure, Strategies to Improve Access to Medicines and Improve High Blood Pressure Control in Low and Middle-Income Countries. Thanks to all of you, attendees, panelists, partners from MSF for joining today to discuss this really important issue of fair and equitable pricing and increased access to medicines to treat the world's leading cause of death, hypertension. I'm sure everyone here knows someone with high blood pressure, someone who's had a heart attack or a stroke. Hypertension is sometimes referred to as the silent killer. It can be a ticking time bomb with a stroke or heart attack about to happen. Many people don't understand that you can feel perfectly well for a life-threatening condition that's brewing with every single beat of your heart. The good news is that blood pressure can be controlled with medicine that is safe, effective, and can be inexpensive. The bad news is that in low and middle income countries, only about 1 in 10 people, less than 1 in 10 people, in fact, with high blood pressure have it under control. Increasing awareness is important, screening is important, but ultimately we need systems to ensure that patients are reliably treated. And that's going to require driving down the price and increasing the availability of life-saving medications. There's more good news. The best medicines for high blood pressure, the very best medicines, are all generic, and they can be inexpensive. The bad news is that they're not inexpensive everywhere. The report today is the first to look at these issues and takes examples from 5 low and middle income countries: Brazil, Lebanon, Nigeria, the Philippines, and South Africa, and has 3 findings, essentially. First, that generic hypertension medicine prices vary enormously across low and middle income countries, with a difference in price by a factor of as much as 40. In fact, if you put together all of the medicines needed to take for an average patient, the difference may be as much as 100-fold. In one country, a government may pay only 1 penny a day for quality-assured, best-in-class medications. In another country, the government or the private sector may pay 100 times that or more. Second, single pill combination drugs, or FDCs as they're sometimes called, that combine 2 medicines, increase patient adherence. They can reduce costs, especially of handling of the medications, but they're often either unavailable or unaffordable. And third, current prices put widespread treatment of high blood pressure out of reach of far too many people who are living in low and middle income countries. And that's why we continue to have more than 10 million deaths every single year. Hypertension kills more people every day than COVID killed at its worst. Hypertension treatment is not rocket science. We have the public health tools to address this epidemic, but we need the social and political will to use those tools. Over the next hour, we'll learn more about how vital it is to increase accessibility and availability, and more importantly, how we can do that. Now, to start today's program, I'm really honored to welcome Olabisi Obelawo, a patient advocate from Osogbo, Nigeria. She'll discuss her experience navigating the challenges of accessing medications for high blood pressure. She is an executive member of People Living with NCDs, an organization affiliated with the NCD Alliance of Nigeria. She's been championing and advocating to improve well-being of people living with conditions like hypertension in Nigeria for many years. And in fact, when we think about this issue globally, we think one of the things that's going to make the biggest difference is to have more advocates like Olabisi. Olabisi, over to you.
Nice meeting every one of you this afternoon. I want to appreciate you for making me a part of this discussion this afternoon. What has prevented me from obtaining high-quality drugs is because, these drugs are very generic. They are very generic drugs that are mostly available and one is not even sure of the quality. They are available at the urban areas. They are not available at the rural areas where many of us are living. Like I told you the other time that my both parents, they died young of this hypertension. Even before they died, they were very sick. that myself and my senior brother had to be taking them from one hospital to the other before they died. And even as I'm speaking to you now, I felt like weeping because I did not enjoy them at all. And I don't want this type of thing to happen to me so that my children will not be carrying me about at my old age. Also, the primary care centers, they do not readily have these drugs, and no preference is given to hypertensive patients in this country. If this primary health care and the hospitals in this country can be given quality drugs, it will help us in a long way. Then accessibility. We need to travel to big cities, like I've told you, to get pharmacies where these drugs are available. And the high quality drugs, I can assure you that I can testify to it that high quality drugs are very expensive, about 100 or 150 naira each per tablet. And just come to think of it, how many we are going to use in a day, in a week, in a month, in a year. They are very expensive. Like me, I'm a retiree of about 10 years now. I retired year 2012, 10 years ago. And my stipend that's been given by the government is not enough for me even to take care of my other household expenses. So I think if the government can be given if the patient can be given the opportunity by the government to be giving all these drugs free of charge, I mean the quality ones, it will give us long life, and we will not die young. Also, there are so many of my friends, my community people, that are having this type of ailments because of lack of, let me say, from our background. So we have so many of us like this, so many civil servants, so many local women, local men in our community that have this type of problems. And I want you to please help us to speak to our government if they can come to our aid by giving us these drugs free of charge and readily available at any time. Thank you very much.
Thank you very much. Oh, sorry, go ahead.
Sorry. Thank you very much, Olbisi, and thank you for your leadership in this area. Your story really reminds us how important it is to address access to hypertension treatment. We have to really make these life-threatening medications available and affordable and accessible for all people, urban and rural, as you point out. Now I'll turn it over to my friend and our moderator, Andrew Jack of the Financial Times. Andrew, over to you.
Thanks very much, Tom, and thank you, Olabisi, for that very powerful testimony. And it's a reminder, of course, there's been a really important and legitimate campaign and focus for many years, of course, around infectious disease treatments. But it's so important to think about in growing parts of the world, including some of the most poor, how non-communicable diseases, including hypertension, are rising to the fore. And even without the scientific challenges with existing and in theory low-cost treatments, how many barriers remain? So a great theme for our discussion over the next 50 minutes or so. For the next half an hour, I'll moderate a discussion with some key individuals with different viewpoints around this. Renu Garg from Resolve to Save Lives, Bente Mikkelsen from the WHO, Emily Kobayashi from the Clinton Health Access Initiative, Faisal Shoaib from the Primary Healthcare Development Agency in Nigeria, and Edwin Mabina from Médecins Sans Frontières. But I'd encourage those of you who are watching already to start using the multiple facilities, including on this Zoom call, to post your reflections, and particularly please your questions, ideally directed to whichever one of the speakers you're most addressed to. And I'll try to move into and respond and get our participants to reflect on those questions as soon as possible. But let's begin perhaps, and we'll start with the report itself. So Renu, you're Senior Vice President at Resolve to Save Lives. You've been talking here about unequal access to life-saving hypertension drugs. So tell us what you would see, what comes out of your report as the key solutions.
Thanks, Andrew. Our goal is to increase treatment for hypertension and decrease costs of medicines. We have 3 recommendations for governments. First, to create standard algorithms for treatment of hypertension. Second, to include fixed dose combination pills in the national essential medicine lists. And third, to improve procurement processes. At the same time, manufacturers can support governments by registering their products more widely in countries. And finally, the civil society can help to generate demand for affordable medicines for hypertension. All of these steps will go a long way in driving down costs of medicines, preventing strokes and heart attacks, and saving millions of lives.
Thanks. And before I go on, Renu, for those who haven't yet gone through the full report, going back to your point there on standard algorithms, so actually the treatment guidelines, how much discrepancy is there, and how far is that a reflection of lack of supply of the best treatments versus perhaps other agendas or historical inertia? What's the kind of pattern like of treatment recommendations?
Thanks, Andrew. So standard treatment algorithms help to standardize treatment, which is there is evidence that they are more effective. When standard treatment algorithms are not used, then governments are procuring too many drugs, and therefore the market is fragmented. So standardizing treatment helps not only to improve control of blood pressure, but it also helps to streamline inventory. It helps to maintain stocks of medicines at health facilities, and it helps to consolidate the market and shape the market to help to reduce costs of medicines.
Thanks. So we'll come back to in some detail to some of those different recommendations. And if any of the panel wants to come back in, even if I've asked to one person in specific, do raise your hand and I'll bring you back with pleasure. But let me turn now to Bente Mikkelsen, Director of Non-Communicable Diseases at the World Health Organization. Bente, there's been, of course, growing debate about universal healthcare in order to tackle this whole challenge of affordability and access and consistent provision of care. How important is that, do you think, on access to hypertension medicines?
Thank you, Andrew. And first of all, it's an honor to be on this panel. And I just want to really underscore the importance of a single person, and that is Tom Frieden. Thank you very much for never, ever giving up on both sort of making a case for hypertension and also making a case for this is one of the major pathways to reach the sustainable development goals. And I have to go through that a little first, because I think on this whole, you might not be aware that we are only very en route to reduce the premature mortality before 2030 in accordance to the Sustainable Development Goals. And we are sort of supposed to reach a target of 30% reduction. And when we then know that 32% of all global deaths is actually due to cardiovascular diseases, and the major part of that is, again, due to hypertension, which has not that expensive, but still a very lack of access. And it has been like that for years. So this is a treatable, preventable disease that can save many, many, many lives. So I just wanted to start with giving that context and underscoring what Tom Frieden was saying. And thank you again for an excellent joint collaboration with Resolve to Save Life. Coming back to your question, I think what we have seen now during COVID and also in humanitarian humanitarian emergency is this very, very big fragility on NCD in general. So the people dying mostly is from non-communicable diseases and people living with hypertension. So what we need is to totally reorient and strengthen the health system. So meaning, if we include NCD into UHC, it means that we can give a financial protection and make available also treatment for conditions like hypertension. So this is absolutely important, and it has to be part of the NCD agenda. It has to be part of also the preparedness agenda and the health security agenda. So utterly importance. Thank you for the question.
And incidentally, Bente, would you say hypertension is a real, as it were, barometer for the capacity of universal health systems to tackle non-communicable disease more generally?
I would maybe rephrase it. So, we cannot expect, because if you look at figures, you will see that NCD has not as, NCD is more than cardiovascular. Everybody on this call knows it's also cancer, respiratory diseases, diabetes. And if we look from 2000 up till now, we see that there is almost no development, no increase in the implementation of NCD into universal health coverage. So what usually happens is that countries need to start a place. They cannot sort of do everything at once. So they need guidance. So both through the implementation roadmap that WHO is working on, and also recent publication like the one from David Watkins in the Lancet, and all the work from Resolve to Save Lives and other partners, we know that a very, very good place to start is actually to focus on hypertension. This has the potential to, with a good investment, but with a much higher return on investment, to save life and to reduce morbidity for millions of people.
Just to be clear and very briefly, but of the scoping that's been done, I know WHO and others have put together these trackers of progress towards UHC. Hypertension, or indeed NCDs more generally, but hypertension in particular, is often an orphan. It's not part of those plans.
So it's very much part of the plans, but when we look at global frameworks completely include all cardiovascular diseases, and we have a very huge focus on hypertension. So that's also why we just recently, which is the basis of the discussion in this meeting, launched a new guideline for hypertension. So we focus on, the three major gaps, both on the lack of diagnosis, the lack of treatment, and the lack of management and control. So it is core to WHO, and it is also a big awareness in the countries. But from the awareness to the action, to actually include on a systematic level, to include it into UHC, is still needs a lot of attention and action. That's what I'm saying.
Thanks, Bente. So let's drill down a little bit now on the question of cost and accessibility around the medicines. Let me turn to Emily Kobayashi, your Senior Director of Non-Communicable Diseases at the Clinton Health Access Initiative. So from your perspective, Emily, who or what's most responsible for determining the cost and the accessibility of hypertension medications?
Price and access are a function of market dynamics, and markets come down to demand and supply, or buyers and sellers. And so I think what the report really does is help us to think about what needs to be happening right now in the market to start nudging the price towards one that would both improve affordability for those patients that have to pay out of pocket, but in the future allow these universal health coverage packages to include hypertension medicines. So I think for the buyers, and particularly for governments, there are really concrete ways that they need to use the funding that they have already to buy smarter. And there are some specific levers that they have, using their budgets that exist, consolidating them across different units, buying together where possible as a way to increase the volumes that are purchased. That's one. Opening up registration pathways, addressing any barriers that are there for quality companies to come and sell high quality products at affordable prices in country. That's another. And there are others about the ways that they use pricing to benchmark their tenders. So there's a lot that they can do with the resources they have now that would actually improve affordability and access right now. But on the other side, there is a call for the sellers of these medicines and those companies that have high quality medications that have a role to play in making those medicines more accessible to patients. And they need to be proactive in addressing these markets. So I think on the one hand, we have registration. That's the first step for bringing a medicine to market. And especially if there are expedited pathways to use those to get those quality medicines available in the market. But also there are things that they can do in the way that they operate commercially in these countries that would actually increase affordability right now. So they can have access relationships with their distributors that enable them to shorten the supply chain and thereby reduce the number of markups on the pill before the patient buys it at the pharmacy. And they need to think about what they're using as their own metrics to improve access to medicines as a focus, not just profit. So I think that there's a lot to learn from this report, and there is a lot that can happen now with the resources that are available in these countries and with the proactive engagement of the private sector that would actually make medicines more available today for patients.
Because we heard from Advocacy at the start about this issue of actual affordability, even though, as we know, a lot of these medicines are available very cheaply, generically, certainly in richer countries. So if you were to look through the sort of, the incremental price rise across drugs that ought to be affordable, but actually often are more expensive in lower income than in higher income countries, what are some of those key drivers? You have more intermediaries, you might have smaller volume of stock, you might have poor payment schedules that perhaps adds to the financial risk for the supplier. What would you see as the 2 or 3 key contributors to that rising cost beyond necessary?
Yeah, I think what we've seen in the cancer medicines market is that it's really driven by the small volumes. And when you have small volumes, that increases the risk for manufacturers, and it makes it difficult for manufacturers of quality medicines to serve those markets directly. So that's where you end up having these multiple intermediaries who are buying the medicines, holding them at risk, and then adding a large markup to sell them to patients. So we want to help the market shift from being high cost, small volume to being a low cost, high volume market where patients have better access.
And you mentioned there cancer, just more generally from your experience, both from other countries where there are best practices and looking at other types of medicines. Any other interesting models to explore that could be applied more in hypertension?
Well, I think HIV is one that people want to think about. And of course, we took the price of medicines for a year of treatment from thousands of dollars to under $100 today. Some of the strategies that we used will be relevant. So I think one that stands out is consolidating regimens, having a shorter list of medications that are in use. That was very important in the HIV space. And also looking at how to centralize procurement and have a few large buyers that can really move the market and negotiate on price. That would also be important. But even if we don't have those large buyers right now, we might need to think about other market interventions that are perhaps more focused at a country level rather than a global level, because the products themselves are not expensive. It's the systems that are delivering them that are causing them to be expensive to purchase.
Just a final precision, you talked about procurement to drive higher volume and therefore hopefully lower price. Are there any models that are or could be applied that are actually even cross-border, so to really drive higher volume pooled procurement between countries?
I think it's an intriguing way to look at things. What we haven't seen is where you have budgets held by multiple entities and national entities. It's very challenging to get people with those different budgets to work together, the different organizations to work together. So that has really been enabled in other health areas by having large central donor procurement budgets that can then attract participation by smaller buyers. But to ask individual buyers to pull together, that can be quite challenging, though not impossible, and it certainly would help the situation.
So thanks. So let's now drill down a little bit into the details at the country level, and we'll look at Nigeria. So Dr. Faisal Shoaib, so you're Executive Director and Chief Executive at the National Primary Healthcare Development Agency in Nigeria. Tell us a little bit about the specific barriers within Nigeria that might have lessons for other countries about accessing affordable and accessible hypertension drugs.
Yeah, thank you very much, Andrew. I think my sister, Mrs. Olabisi Owale, started talking about some of the challenges, with accessing hypertensive medication in Nigeria. But to put it in proper perspective and to really contextualize it, we're looking at a country with a population of over 200 billion. Nigeria is often referred to as a large country with multiple smaller countries within it. So the prevalence and the context of hypertension really will differ from region to region. So, for example, there's a study by Odili et al. In 2017 that indicated that there's variability in the prevalence of hypertension from just about 20% in the North Central region to as high as 53% in the Southeastern region. So despite the differences in the prevalence, there are common threats in terms of the reality of hypertension. So one of the biggest challenges that we face is that of awareness, right? A lot of Nigerians are not even aware of the signs and the symptoms of hypertension. In a lot of cases, hypertension is only discovered when a patient goes for routine tests, right? And these routine examinations or assessments are not frequently done. So many people go several years without a physical, and it is sometimes in the course of addressing one medical challenge that hypertension is discovered. And then when you also consider the fact that there's a low risk perception, around hypertension, people tend to think that hypertension is what they call a disease of the affluent or a big man's disease. So only those people who live in the urban areas tend to have hypertension. When in actual fact, the problem is more that of a lack of diagnosis rather than a question of whether hypertension exists at all. Now, there are also institutional, challenges when you look at why there's a relatively low incidence of hypertension. Again, like I mentioned earlier, it's more that this diagnosis is not taking place. So even within the primary healthcare space, for example, the human resource, availability is well below what is expected, right? So the WHO, for example, provides that there should be a patient to doctor ratio of somewhere around 1 to about 600 or something like that. But in Nigeria, we're looking at a ratio of about 1 to 5,000, right? This just for even medical officers. Even within the primary healthcare center, up to 27% of primary healthcare centers don't have the requisite human resources that can even, diagnose, hypertension. So you have a huge problem with the diagnosis, let alone treatment. And then when you come to treatment, my sister Olabisi has, in her introductory remarks, mentioned the fact that these medications are either, too expensive, or there is a myriad, a multiplicity of these medicines that don't follow the standard policies or global guidelines, right? So you now have a situation where not only is the diagnosis not done, but even when it is diagnosed, the treatment is either not available or too expensive, right? Out of touch. Why is this the case? Most Nigerians actually have to pay out of pocket for their basic care. So over 75% of Nigerians have to pay out of pocket for their medical expenditures. This is why it is important that government now, is in the process of signing into law mandatory health insurance so that there's pooling of resources and then we can reduce these types of out-of-pocket expenditures. So the reality is there that if, for example, you're a retiree like Olabisi and you do not have a steady source of your pension, then you will continue to suffer because you will probably have to look, to your relatives or get loans or sell off some of your assets to be able to pay for hypertension medication that is already too expensive. This is why our work with Resolve to Save Lives is very, very important. Thanks to the leadership provided by Tom Frieden, we've had multiple engagements, and we've now come up with a national multi-sectoral action plan, for hypertension, and this is helping us, begin to focus on the priorities to reduce the incidence of hypertension in Nigeria. So I'll just pause here.
Yes, and again, you come back to that really important point about universal health coverage and the issue of the challenge presented by out-of-pocket payments. So just Faisal, tell us, what you would consider the key thing, perhaps, that governments and manufacturers could do to raise affordable, accessible access to hypertension medicines.
Right. So first and foremost, government, is already stepping up, how we can transform the primary healthcare space. So just a few weeks ago, we had a primary healthcare summit, a global primary healthcare summit in Nigeria, to try and address the basic tenets of providing basic care for all Nigerians. And of course, hypertensive care is very, very critical. And what are these issues that we're trying to address in the primary healthcare space? It is the issue of, human resources, making sure that we have adequate trained human resources that can, for example, understand, diagnosis of hypertension, have a, high level of suspicion, right? So that every patient that comes at least has as a minimum that assessment for hypertension, making sure that the primary healthcare centers have the right infrastructure and the right financing. So pooling of resources to be able to provide care. This pooling of resources, of course, cuts across what you're going to use these resources for, whether it's for the materials or even the drugs, right? So really, really important that as we pool resources together within that primary healthcare space, that these resources also go towards buying the cheapest and most effective hypertensive medication that aligns with the global standard. But of course, we cannot overemphasize the supply side, without also talking about the demand side, which is also creating and propagating the demand for information and the knowledge about hypertension. This is something that, as government, we have to continue to do, to provide that information to citizens about, hypertension and what the simple measures are to prevent and to treat hypertension. All of these are neatly sewn into the multi-sectoral action plan that we have jointly developed with, Resolve to Save Lives under the, with the leadership that our Federal Ministry of Health is providing. And so, I want to seize this opportunity to appreciate, Tom Frieden and the organizers of this panel discussion, because what it really provides is an opportunity to raise awareness, about hypertension and how it is a huge burden on middle income, low and middle income countries like Nigeria, and the fact that it's a silent killer because there's diagnosis of the conditions, and all of the efforts that are being pulled together with our partners and donors to ensure that it's easier to diagnose the disease, and also making sure that people are better able to pay for the medications are very, very critical. I do not know if we'll ever get to where the medication can be provided for free in Nigeria, but I think the first real step is how we can provide, pooling of, resources through insurance to make sure that those that can pay for the health care can pay for them, and for those who cannot pay for the for healthcare services that the vulnerable people actually have the opportunity to have their medications paid for. Thank you very much for the opportunity.
Thanks very much. We were hearing, you touched briefly, and we'd heard earlier about single pill or fixed dose combinations. Maybe let me turn to Edwin Mabena, your head of clinical activities at Médecins Sans Frontières. So Edwin, tell us from your experience, why are those single pill combinations important in managing hypertension?
Thank you very much for the time. Can I take you back and remind you that more than 1 billion people globally have hypertension, and which is a silent killer responsible for approximately half of all heart diseases and strokes. And from data that we got from scientific days in Zimbabwe and Jordan, it points to the fact that these patients require more than one medication to achieve BP control. And some of these patients also have other comorbidities that are inclusive of HIV, TB, diabetes, among others, which complicate their adherence to treatment as a result of increased pill burden. So we found that treatment with fixed dose combination, single pill medications, is a best practice that is emerging, which is safe, effective, rapid, and convenient for hypertension control. In the setup of Eswatini, the NCDs, hypertension included, are still neglected as far as resources allocation is concerned. In Hlangano Zone, where we work in the Shiselweni region of Swaziland, there are always intermittent stockouts of hypertensive medications. You find patients that are initiated on treatment. Today, they get this medication. Tomorrow, they get another one. So for example, today, a patient who is in enalapril will come for a review. On another day, they will get nifedipine. On another day, they will get methyl dopa. Then that makes it complicated for healthcare workers to monitor them using the stepwise approach. As such, the single pill combinations come in handy to alleviate such issues of challenges with access. And again, Eswatini is moving towards nurse-led NCD program, where nurses can manage the NCD, all the NCD conditions at primary care level. So the presence of single pill combinations makes it very easier to task share between the doctors and the nurses, because it is simple. It has simple schedules, which again makes it very simple for patients to adhere, and the algorithms are very simple, making the nurses to be able to follow them. There's also increased chance of achieving target BP control due to better treatment adherence when using single pill combinations. In other settings, we can say there's also simplified logistics for supply chain, which will mean that there will be fewer stockouts for these medications. What we notice that in the context of Eswatini, Ministry of Health and MSF worked hand in hand in coming up with a protocol and the algorithm for implementation of the single pill combination. Protocol was developed by MSF in Eswatini, and then which was approved by the ministry. There's a good working relationship between MSF and the Ministry of Health in Eswatini. So as we were implementing, I've mentioned already to say the greatest drivers for this implementation were issues of law control, that is evidenced from the data from Zimbabwe and Jordan, also the pill burden for the patients. And then we note that from that, it becomes a challenge for the program. Hence, MSF came in to say, we'll give this support. And then we learned that in the provision of this support, there was a great challenge that MSF faced, which was mostly related to the procurement of the single pill combination. there was a lack of a reliable supplier, and it was also due to limitations, which meant that we were supposed to purchase large quantities. In Africa at the moment, it's only Eswatini that is implementing the single pill combination. That means that pulling up of resources is not feasible at the moment, hence making it very difficult. There's one supplier at the moment, again, for the single pill combination that we were sourcing from. And that I think, again, can show you how difficult it is to get the medications into our context. And then from the lessons that we have learned so far from the implementation of the fixed dose combination or single pill combination is that it benefits the health system as far as tax sharing is concerned. It improves adherence to treatment. And if there's adherence to treatment, we know there is going to be achievement of the target BP control due to a reduced pill burden. As I've already alluded to that, a lot of these patients have comorbidities that require them to take a lot of medications other than the hypertensive medications. Thank you.
Thanks, Edward. And just one slightly technical question, titration.
Yes.
So if you have a single combination, obviously you're making certain assumptions about the active dose required, but obviously different patients of different ages, genetic differences, body mass index and so on. Is there any evidence that that creates some suboptimal treatments if you have a single standard or maybe two even types of fixed dose pill?
For at the moment, I can come up and say again, that is one other challenge that we faced for titration, because for the adults, the dose that we were starting with for lisinopril and amlodipine, we're starting with a lisinopril 10 milligrams and then amlodipine 5. So then if we have to titrate, then we couldn't get the combination, say for example, the combination of lisinopril 40 milligrams, which is the maximum dose, and the amlodipine 10 milligrams, that is the maximum that a person can take. Then if we were to titrate that way to increase, then it meant that a person again was supposed to get either 2 tablets, or if we were to reduce, it becomes very difficult again to reduce, because some may require, if we require less than the 10/5, then there is no combination again. Yes, it is really a challenge if the options are not available. The options that we only managed to get was the 20/5 and then the 10/5. That limited our titration requirements, as we already had said that we needed to reduce the pill burden for our patients. Again, if we are to titrate up, then it meant that the patient will have to take 2 medications of the 20/5 to get to 40/10. So it is really a challenge. We would have wanted a scenario where we have ease of titration based on the availability of formulations that will be user-friendly. But to make do with what we have so far, we can say it's better for now. But we foresee that we will still get challenges as we go ahead.
Okay, thanks. I'm going to open it up very shortly to questions. So do please, those of you who are watching, do post any questions now around this really important issue. Maybe let me go back, perhaps in the first instance, to Emily. We were talking about comparisons with ARVs for HIV and so on. Do you see, but we know in the areas of non-communicable disease, there's been much less action by foreign governments and other donors. Do you see there is some scope and perhaps some strategic niche areas where donor support could actually, or is already, offering catalytic support for this issue of greater access?
Yeah, I mean, I think donor support was a huge game changer for the price of antiretrovirals. Having large quantities of assured demand for a limited number of products meant that you could have price negotiation, you could have generic manufacturers make the investments to start producing the products at lower cost. that was really the key, one of the key things that turned the tide in pricing for antiretroviral treatment. So it would make a huge difference. However, one thing that's different in this market is that we already have a number of excellent antihypertensive medications that are available generic. As the report points out, the cost to produce them is quite low. And there are a number of suppliers who already have a stringent regulatory approval, which demonstrates that these medications are very high quality. So I really just want to reiterate that I think we can start now. We don't need to wait for something to change in the global donor landscape. We can work with the resources we have now and make a big difference for patients today in addressing prices. And that might mean starting from the national level and working with national governments to pull demands inside of countries to lower barriers to entry for those to those manufacturers, and also to improve affordability for patients. We can start now.
I'm just wondering whether there's any, whether it's technical assistance or issues around transparency of pricing or supply chain and forecasting or whatever, where already there is or there could be some perhaps easy additional wins. Any thoughts?
Yeah, I mean, I'd love to see support to governments, including, Nigeria, but many others, like the support the Resolve to Save Lives provides now in terms of planning, thinking about those pooled funding mechanisms, thinking about those procurement mechanisms, moving towards consolidated regimens. All of those things take time and effort for governments to do. So implementing those changes now is definitely something that donor support would make a huge difference.
And Bente, perhaps, we've heard already discussions about the different regulatory regimes, about the essential medicines lists, about the challenges of country-by-country registration, that not all manufacturers then necessarily go through the hoops to do in some countries. So do you see through the WHO or through some of the other international organizations, there are some gaps or there's scope for them to step up more to try to accelerate and harmonize?
First of all, I'm very much in agreement with the last speaker that there is no reason to wait. So I just want to again emphasize that we had normative work, but we did miss the big piece that is now in place, namely the protocol-based treatment. So the definition of this treatment, sort of scoped down to a few molecules that we can actually focus on. So now there is an open road to be able to do more kind of, we can think about pool procurement, we can think about common joint forces for regulatory harmonization and so on. So what we will do in June from WHO side is we have regular meetings with the private sector. So this is engagement with the broad scope of private sector, also including devices, by the way, because it's not only about pills, it's also about the measurements. And we will develop the asks based on what we know is the barriers. And we have done this for diabetes on specifically insulin, and we can see that the commitments that we get is very promising. But I think this is a place where we need all partners together. We need to work on regulatory basis, we need to and harmonization, and we need to work on forecasting. And of course, we need to continue the technical support to countries that we do from WHO and implementing partners. And we need to continue the policy dialogue, because as we heard from the beginning, our person living with hypertension, I think I say it correctly, Obelavo, she was very clear that the financial hardship around this is one of the major struggles. So I think we have in place what we need from the normative side, and it is time to act. And it would be great if we could do it together with partners like the ones on this call. And we are, of course, looking for support from development agencies as well to realize this in the near future.
Okay, thanks. So we're talking here about funding. It's a good moment to move to questions. So again, I'd encourage people to post queries they have for the panel in our remaining minutes. And we have one here from Dawit Bizrat, who says, cardiovascular disease is a global burden and a leading cause of death, but global health funding is very low compared to infectious diseases. Why is that? And are there any innovative strategies to increase government funding to tackle this threat to hypertension? I wonder, Faisal, perhaps I might start with you. You talked earlier about this issue of funding. Why within Nigeria, perhaps, is there this, if you like, imbalance or insufficient funding, and how could it change?
Yeah, thank you very much. The issue of funding is something that predates the current sort of crisis that we have within the health sector when it comes to lack of financial equity. In the past, you've seen a situation where whenever there are donors or development partners that are interested in one specific disease, then you see a deluge of resources coming to support government. But where you do not find that sort of stakeholders, generating domestic resources for these types of diseases, then it is difficult for you to pull together a plan and an implementation strategy that can, address this disease. So pretty much in most low and medium income countries like Nigeria, you find, a silos kind of situation, a verticalization of program based on disease entities. So even as we talk about the challenges with hypertension, we are best informed if we look at it from an integrated point of view. So hypertension is very, very important, but so is malaria, so is maternal and child death, right? So how do we ensure that with all of the lessons we've learned about how not to implement programs, how not to verticalize programs, how do we make sure that we also integrate hypertension into our programming, into the primary healthcare space in a way that ensures that we optimize all of the resources? The challenge has always been that when we focus on one particular disease, then we throw all of the funding to that disease. And once the funding, is taken away, then you find a situation where, all of the gains are now reversed. So those are not sustainable, frameworks for implementing disease control. So I hope that as we move forward into the future, that we do it in a way that is integrated, so that it is not that we have more money for, HIV/AIDS programming, or we have more money for family planning, depending on, the flavor of the month, the flavor of the year, depending on what the donors want, but that there is, a systematic way where government is encouraged to make domestic resources available, that is advocacy to government, and all of the, plans are around making sure that once an individual comes to a health facility, there's a whole of family approach, right? If it's a woman that you're looking at, her reproductive cycle, and also, her, risks for non-communicable diseases such as hypertension, and all of those assessments are done, and all of the resources that are available are channeled towards making sure that, that individual is assessed as a whole, and not just based on the different, disease entities.
Okay, thanks very much. So we'll move to Sanjay Pandey here, who asks, this is for you, Renu. What's your reflection on the quality of healthcare and equity? How can it be assured using universal health coverage? Any thoughts?
Thank you. 9 out of 10 people with hypertension do not have their blood pressure controlled. So there's huge undertreatment. And the way to increase equity is to make services for hypertension as close to the patient's homes as possible. That means investing in primary healthcare system and increasing access to treatment for hypertension at the primary healthcare centers closest to patients' homes. Another big barrier to treatment access is the high cost of medicines that this report highlights, and the variability in costs of medicines across countries. So it's really important to take for governments to increase, to create standard treatment protocols, to include essential and NCD hypertensive medicines in their essential medicine lists, and improve procurement in order to improve access to treatment for everyone and help to save millions of lives.
Okay, thanks. We're running short of time, but there's a question here, and I was going to ask this as well. So, Olabisi, if you're willing to come back in, then there's a question here from Doris Mugrichian saying, how did you establish your patient advocacy group? Because obviously patient advocacy, as we've discussed, is perhaps a really important aspect of pushing governments and others to respond. So what if you had two key messages on how important and how to build patient advocacy that's effective, what would you say?
About the patients here?
Yes, patient advocacy. Yeah. How do you build pressure from patients themselves to try to get the system to respond more effectively to hypertension?
I think I will advise that patients that are hypertensive, they should go to the hospital. They should try as much as possible to purchase their drugs if they can. And if not, they can contact anybody that can be of help to them so that they will not die young. That is my advice.
Okay. Thanks very much.
Thank you.
Thanks. So we're almost out of time, but there's a couple more here. Perhaps I'll take one here on from Lisa Ware and Stephanie Lucas, what's the role of pharmacists and community health workers in this initiative? Maybe Emily, do you want to come in on that?
Yeah, I mean, I think it comes back to the protocols and the opportunity to expand access through using protocols. And that really opens up the cadres of health workers that can be involved with the delivery of hypertension care. So definitely, looking for opportunities to decentralize care so that it can be closer to where patients are. And many different cadres of health workers can be involved in that.
Okay, thanks very much. And there's a question here on very important one from Ken Cornell on how can we leverage the urgency of COVID-19 and vaccine access to accelerate access to hypertension medicines in lower and middle income countries. Bente, do you want to come back on that?
I can, but I think it's a very important question in the chat that I need to address, because it says that the push from WHO is sort of prohibiting the focus on hypertension. And I want to really answer that question, because we have already stated that hypertension treatment is a pathfinder for UHC and SDG. And we have to start somewhere. And WHO is very clear that this is the place to start. We have the normative work, we have the treatment, and we need to strengthen the health system in an integrative way through the route of hypertension. And also on the domestic funding, I think we don't use really the opportunities. There are opportunities to include hypertension treatment in all the proposal going out from the Global Fund, from the World Bank, from other calls for proposals. So this is really something we need to do at the country level, region, and global level. And very last on the funding, because of course all the global architectural funding structure was established during the Millennium Development Goals. So they are all about HIV, tuberculosis, and malaria. And we don't ask for a new global fund for NCD, but we ask for seed funding and also funding that comes with a form of predictability, as we have seen now from, for example, the Development Agency from Norway. And we also need to do whatever we can to strengthen the domestic funding. And one of the ways to do that is also to focus on the risk factors on NCD. So there is no hesitancy from WHO and there is a very high level of urgency actually to support this work. So I know I was not polite, no, Andrew, but
you're at a very important point. I'm afraid I'm going to have to be impolite now, though, because we've run out of time. But I will perhaps, as I hand back to Tom, whether he wants to just sort of reflect on that question about lessons from COVID, amongst other things, as part of the closing. But meanwhile, thanks to all of our panelists for their great interventions.
Thank you very much, Andrew, for your moderation. Thanks to all of the panelists. Sorry we didn't get to Dr. Faisal's last comment, but this is the beginning, not an end, of a conversation on increasing access to antihypertensive medications. And I've been reflecting on the bad news and the good news. I'll give you 5 and then we'll close. Bad news, hypertension kills more than 10 million people a year. Good news, most of those deaths can be prevented. Bad news, less than 10% of people with hypertension in low and middle income countries are effectively treated. Good news, safe, effective, and affordable treatment exists. Bad news, drugs are currently unaffordable for most people. Good news, they can be affordable. Bad news, there's chaotic therapy choices currently in the public and private sectors. Good news, the best medicines in the world are generic and inexpensive. WHO has now published recommended regimens, and more countries are selecting those regimens. Finally, bad news, hypertension has been an enormously neglected area. Whether or not there is good news about that, whether we are going to end that neglect, will depend on all of us. Will depend on patient advocates like Olabisi and organized patient groups and healthcare workers demanding good quality treatment. It will depend on great NGOs like MSF and CHAI, who are our partners in this, pushing. It will depend on government leaders like Dr. Faisal, ensuring that they're implementing evidence-based and cost-effective programs, and continued leadership from WHO to shine a light on hypertension and what more needs to be done, as well as our friends in the media like Andrew, emphasizing that hypertension treatment is a best buy. It can save many, many lives and address interests. And on this last issue of COVID, I will say that for more than a decade, I've been hearing voices in low and middle income countries saying to me, when we in US push for control of Ebola or polio or measles or drug-resistant bacteria or COVID, you know, you're pushing for this in control here because it's a risk to you there. Do you really care about us as human beings? Do you really care about us as people? And I think globally, if we don't muster much more commitment to address the world's #1 cause of death, hypertension, the answer to that question will be very uncomfortable for countries around the world. Thank you very much for joining us. Thank you to all of our participants, our attendees, our panelists, our patient advocate. Thank you. And this conversation will continue. Please check out the full report, which is available, and we'll close now. Thank you very much.